Hello, my name is Mo, and I'm really delighted to be here with you today. Thanks to Wendy, Annie, and the conference team. I'm a mother of three, a teacher, a writer, and so much more. I'm passionate about maternity improvements and development, and I wear many hats in this regard, locally, regionally, and nationally. I'm here today to share aspects of my maternity service experience with you in relation to ethnicity and health. My experiences of the maternity service as a mother and along the way as a service user representative started over 8 years ago. I was an ambitious teacher at the peak of my career, a healthy, confident professional woman with a low-risk pregnancy when I was first referred to the maternity service. I was a patient, even though pregnancy is a normal physiological occurrence without which any of us here would exist. It's not an illness. There are so many stories I could tell you about my three experiences, from undesirable cascades of intervention to health professional-centered information that resulted in fear-based decision-making, to inadequate information from different health care staff about breastfeeding. Words cannot describe the resulting deep darkness that accompanied some of these things for me as a first-time mother. Mothers in the maternity service have a whole life beyond their pregnancy and birth. And pregnancy and birth, as we probably all know, impacts women and families in life-changing ways. For some of us, our maternity care experiences literally changes the course of our lives, for better or worse. I still remember a moment during my first labor experience, in the thick of intense surges that gave me a deeper level of respect for mothers worldwide. When I was told why my waters couldn't be broken, it was something to do with my African pelvis, which still baffles me today. Did I really at that point need to know that my body was a different kind as I battled through the most painful of squeezes, unimaginable, difficult to capture in words, in those most intense of moments like nothing I had ever experienced before? I have no doubt that the staff meant well, but over 8 years down the line, I still don't know what to make of it. One thing for sure is that my pelvis, regardless of its continental connections, did pretty good the second time around and amazingly brilliant the last time. Words are powerful. They have a way of lingering, molding and changing so much of our lives. We do well to be mindful of this. I can also tell you many good stories. After the eventual awakening of the mama bear within to mend and find ways through the brokenness the system had left us with, from researching and supporting myself to becoming a partner in my own care, no longer a patient, and even more, becoming a partner in maternity development and improvement, starting with when I first put myself forward to chair my local maternity voice partnership some years ago. I can tell you about health professionals that made me feel like a waste of space, and ones that embraced my multitude of questions in my attempt to better understand. I can tell you about unhelpful staff who ignored my new mother's plight to my crying baby struggling to breastfeed in the middle of the night on the postnatal ward with a painful C-section scar. And also about the amazing staff who worked with me, like Dr. James and midwives Lisa, Gemma, Alice, Vicky, and many others, to have my VBAC to at our birth center, even though this had never been done before at my local hospital. I can tell you stories of staff whose job I would have made easier if I just gave up on breastfeeding. And my health visitor the second time around, Diane, who showed me incredible empathy and compassion, actively listening to my every word, going the extra mile with the extra appointments I needed in my own home. And the dark cloud of 5 times more likely to die social media messages that dominated my last pregnancy, despite the mostly excellent care I was receiving at my trust. The moments of panic and worry where I thought I better write letters to my young children in case I didn't make it through. Moments where I desperately tried to understand what the data meant without understanding the difference between population and individual risk. None of us should individually be the collateral damage for population level statistics. I've often wondered about the wisdom of lumping vast groups into single terms when addressing disparities. When we, for example, talk about Black women in the UK now being 4 times more likely to die, and Asian and mixed ethnicity women around 2 times more likely to die, I've wondered which Black, which Asian, which mixed ethnicities. There are, for example, 50-something countries in Africa, 13 in the Caribbean, in addition to about 20-something overseas territory there, and 48 countries in Asia with 3 territories, many of whom are represented in the UK. Don't you also wonder which Black, which Asian, which mixed ethnicities? Mothers from ethnic minority backgrounds, like any other mother, are whole people. We're all more than our skin color or any single characteristics about ourselves, especially those we haven't chosen. I'm sure everyone wants the best care possible from the right people at the right time, regardless of ethnicity and skin color. I share Dr. Martin Luther King Jr.'s age-old dream. Skin color should not be a quality of care determinant. Our NHS, a renowned institution for the people, by the people, for us and by us, is there for every single one of us, regardless. I have lived and visited a number of countries on multiple continents across the years and learned about more. And I know that what we've got in the NHS is pretty good. It is important to acknowledge that there are multiple silver linings amidst the clouds. The NHS is at work, and the multiple examples of improvement are encouraging, as so many across the country work for a better NHS for all of us. And so today, at this moment, right now, right here, I ask you to join me in asking, isn't it time for research to deep dive into data that disparities information are as specific as possible, measures as targeted as they can be, so that definite progress is more feasible? Isn't it time for evaluation of training to support caring for mothers from diverse ethnic minority backgrounds to ensure they don't perpetuate a one-size-fits-all approach? We know that personalization is key to better outcomes for all. Is it not time for all mothers to receive information about their Maternity Voices Partnership, as well as other local, regional, and national complement and complaint channels at their booking appointment and also at discharge, so that more voices inform maternity service improvement and development? Is it not time for trauma-informed and psychologically safe restorative justice program to support reconciliation between health professionals and mothers with their families when care goes wrong, in finding peace and ways forward? And is it not time to consistently care for the carer? None of us can pour from an empty cup. Staff cannot make the space or give the time to care that has not been given to them for caring. How can they give excellent quality care if their well-being isn't prioritized? What about a maternity journey peer support buddy program to support new mothers with allied health service professionals like breastfeeding counselors and doulas working for the NHS to support mothers with informed decision-making alongside clinical staff, supporting the nurturing of a culture of accountability and safe care for all? And won't this definitely make a difference? Guaranteed personalized care through continuity of care with choice, an evidence-based improvement measure for better maternity experience and outcome. I mostly have the same community midwife, lovely Helen, at the same trust for my antenatal and postnatal care with all my children, and what positive difference it made to my experience. Intrapartum continuity would have made it even better. I could go on, but time is not on our side. So please listen deeply, compassionately, and actively today. Pledge to be part of the change we all want to see in your words and work, in the care you give and the power you have. It is time for action, and every little helps for better care for mothers and babies with their families, regardless of ethnicity or skin color. The time for waiting is over. It is up to you and I. It is up to us from this very moment to do all we can to act now for a better NHS, a better maternity care for all regardless. Thank you for listening.
Excellent. What a powerful video. Thank you for that testimony. And what I love about that is just really the focus on solutions and what we can do. So thank you for that introduction. Today, I'm really excited to be a part of this panel. I think there's just a wonderful opportunity to hear what's happening and also to hear about current context and solutions. And just the one thing to add, what I bring to this, as my experience as an OBGYN delivering babies and helping birth babies, and also working in the global space and in policy, and now through philanthropy, really being able to bring all of those experiences and partner with all of you to really think about how we can change this issue. My comments today will really complement a lot of what Dr. David Williams talked about, and our panel and conversation will focus on what can we do to make change and to really understand what's happening now and how we can learn from each other as part of this global experience. If we go to the next slide, please. Actually, I can do that myself. And so one of the important aspects that we have to consider is when we think about maternal health and maternity care, we have to understand it as part of the broader context. We often, as healthcare professionals, as just society, tend to silo out maternal health as this other thing. But all of the comments and research that Dr. Williams so eloquently stated early on actually apply to women. And also, we also have to think about this intersectionality context as well when we combine race and gender and just the ultimate additional impacts that provides. And so as we think about these systematic and structural determinants of health, whether we're talking about racism, classism, gender oppression, sexism, ableism, heterosexism, and if we apply that on to race as well, and the connection of each of those impacts really is something that's really important for us to consider. But also, we also have to understand the root causes, as we can't separate this maternal health care crisis from lack of childcare education, lack of social infrastructure, and it can't also be separated from the lack of investments in communities and the lack of investments in these other drivers of healthcare that we see here, whether we're talking about education, access to good healthcare, access to safe and communities, access to jobs that provide, at least in the U.S. context, your job determines your access to insurance as well, because we don't have a universal healthcare system. And so applying that to these other policies that really produce racial inequities in each of these determinants. And what we see is that there's strong relationships between severe maternal morbidity, race, ethnicity, age, whether we're talking about region where people live, community level income, and hospital type. At the Commonwealth Fund, we've collaborated with a number of researchers to better understand how severe maternal morbidity across each of these impacts and several demographics impact outcomes, and we see that there are vast racial and ethnic differences as well. And in the U.S., this isn't a new problem. We've seen through the data that Black mothers have been more likely to die than white mothers for about a century, for as long as we've had data collected. And so we have to really understand that we need an intentional focus on eliminating these inequities. It's not a matter of let's raise all boats. We really have to understand the root causes of these inequities and intentionally address them. Those who die or experience morbidity are more often than not Black or Indigenous people, and the birthing room is just another place where systemic racism takes a toll on Black and brown families. And let's talk about some of these root causes, and I really want to just have this conversation also to set our framing for this panel as well. We have to look at issues in new ways and ask deeper questions if we're really to succeed in advancing Black maternal health equity, Indigenous maternal health equity, and maternal health equity for all of us. As I discussed in a commentary with the American Journal of Public Health, if we apply this root cause analysis approach that we apply to healthcare in general, that'll really help us understand looking at this issue in new and deeper ways. Like, why are Black people, for example, experiencing higher rates of maternal mortality? We can stop and say, oh, because of eclampsia, because of postpartum cardiomyopathy because of obstetric embolism. But why is that? Why are there these higher rates of these conditions despite being 60 or 70% preventable? Well, we see that there are increased comorbidities and stress. Dr. Williams talked about the weathering and just the impact of racism, living in toxic environments, and on people's lives, delays in reaching and accessing high quality health care, and then also presenting with more severe symptoms and more advanced disease because of these delays. And so then why? Why do Black people and pregnant and birthing people do not receive risk-appropriate care based on standards? Well, less access to health care overall, concentrated use of hospitals with poor quality indicators, what we can term medical racism or medical segregation, and not being listened to by providers. As you heard in the video, just people asking for health care, asking for help, but not being listened to because of pre-existing assumptions. And then why is that? Why do we have these factors of decreased access? Why do we have that disproportionately affecting Black birthing people? Well, we have to also understand and talk about structural and internalized racism, the intersectionality across gender and race, residential segregation, access to poor quality hospitals, insurance coverage inequities, implicit and explicit bias of providers, this individual racism that Dr. Williams talked about, and the disproportionate impact of the drivers of health. And so that really brings us, if we think through the 5 whys, this legacy of systemic racism, this hierarchy of human value that's really entrenched in our practices and policies that we really need to address in health and healthcare. I also think it's important as we think about the context we're in now. We have a shifting landscape where we have these collision of crises. COVID for many unveiled the impact of racism on people's lives, and there's this more of an awareness for those that haven't been doing this work, a broader coalition of people that are engaged and interested in really making a difference. And so as we think about this coalition of COVID-19, of the economic impacts, and of this maternal health crisis, and also in the U.S. in terms of reproductive health policy changes that are impacting many women, we also have to understand that as we think about advancing maternal health and women's health, we have to think about new models of care, of high-value care that are emerging. Here, not necessarily in terms of midwifery care, that's really a clear standard in the U.S. context. That's an area that we are increasingly talking about and increasingly thinking about bringing policy change to so that we can have more midwives invest in more midwifery care. Increased opportunity for having birthing centers and telehealth and engaging community, really thinking of integrating community partners and addressing the social drivers of health, ensuring that we can support community health workers and doulas to really be able to provide for care for people, and also an expanded role in the United States for our public health insurance coverage to really also think about these postpartum models of care. Care for pregnancy, for birthing people, for pregnant people does not end at birth. And so in the US, for example, one of our insurance models would end coverage 60 days after someone had their child. And so if we imagine, when we look at the data around maternal mortality and morbidity, a lot happens between birth and 1 year. And so really there's just new awareness of the importance of postpartum care, as was highlighted by our video today earlier. And in terms of advancing racial equity and reproductive justice, we also can't think of that as an isolated context. As we have our conversations around inequities of racism, unequal treatment, and outcomes, we also have to incorporate the gendered context of this as well as the importance of advancing diverse leadership in this work as well. So having said that, I'm really excited to introduce our panel today. If we introduce our panel today, I'd like to call them up. First, I'd like to introduce, we have a Professor Jacqueline Dunkley-Bent. Thank you for joining us today. Professor Bent is a Chief Midwifery Officer for the National Health Service in England and co-chair of the Observatory's Maternal Health Advisory Group. And co-chair of the Reproductive Health Observatory Maternal Health Working Group, as I mentioned. Dr. Daghni Rajasingam is Chief Obstetrician for Southeast England and consultant, is OB consultant with a specialist interest in inequities in maternal health care. Thank you for joining us, and co-chair of RHO's Maternal Health Advisory Group. Benash, Nazmeen, thank you so much. Nazmeen, thank you. Professor Benash Nazmeen, Assistant Professor of Midwifery, University of Bradford, and also a member of the RHO Maternal Health Working Group. And Tinuke Awe, thank you for joining us, a Black maternal health campaigner, co-founder of 5X More, and an early years diversity inclusion champion in the UK and member of the RHO Maternal Health Working Group. So I'm going to join them at the panel, and we're going to have a really exciting conversation today. So thank you all for joining us today. Oh, that's why. Thank you all for joining us today. I'd like to start with Professor Dunkley-Bent. There's so much that's been happening in the NHS around maternity care provision in England. Can you start out, and since we're starting off and talking about solutions today, can you talk to us about what plans are in place to improve equity in maternity care provision in England?
Absolutely, and thank you. It's a privilege actually to be able to contribute. And before I start, I just wanted to say, having Mo share her maternity experiences on the screen just now, speaking authentically, was absolutely amazing. And I think what's really important and significant about maternity care in England is that the user voice should be front and centre, and that's the message that we consistently give to maternity providers. If we have maternity care that's front and centre, if we have women and families that are placed front and centre, everything we do in maternity, we will be on the road for safer, equitable maternity care. There is something about listening that we need to take seriously, and I wouldn't even just stop with listening. We need to listen, then we need to understand, because many people listen and hear, and then they get on with the day job. So listen, understand, and then act in a mutually agreeable way, which means that you are taking the woman with you. You have to understand, and then the mutual agreement to act. But what I would say in England, we know the data. Of course we know the data, that Black women, Asian women, women from a mixed ethnicity background, socioeconomically disadvantaged women are 4 times more likely to die in pregnancy. Yet we know that we have one of the safest maternity care systems in the world. But there is a disparity that sits within that. And I think for the disparity, we need to focus on really not changing. There's something about changing the narrative, I think, that we need to do. Change the narrative and not do the same as we've always done. So at NHS England, we published an equity guidance that will really set the tone about what our 124 maternity providers do for our 600,000 women that we support to birth every year. That guidance will be the framework for how we level up, how we ensure equity, how we ensure that regardless of postcode, regardless of the clothes that you wear, you will receive the outcomes that women that have the best outcomes receive. And that's the ambition of the equity strategy. We have made strides in terms of improving perinatal mortality. You might not believe this, but the data tells a compelling story. And the data tells us that the gap in inequality in health outcomes is reducing. Just by way of an example, 5 times more likely to die in pregnancy, now 4 times more likely. Just by way of comparison, the stillbirth rate for Black babies in 2019 was 7.1 per 1,000 births. In 2022, it is 6.3 per 1,000 births. Now, I'm going to stop there and say that data is absolutely essential. We need more. We need to get better with our ethnic coding. However, data obscures the human experience. So regardless of the rate, regardless of the number, there is something about stepping into that space, changing the narrative and doing something differently. And many interventions, we have toolkits like the Saving Babies' Lives Care Bundle that are making strides with our preterm birth rate for babies 24 weeks and above gestation. We have network maternal medicine clinics. We have perinatal mental health services across England. I'm personally leading on that. We have an immigrant population that are less likely, says the empirical evidence, to share their mental health concerns and any form of depression or anxiety they might have. They're less likely, so we need to step into that space. So there are many initiatives happening in England. What I would say is we base our strategy on the concept of proportionate universalism. Love it or hate it, it's a Michael Marmot principle. I love it. We need to provide, and we are providing, healthcare, maternity care at scale and intensity that is equal to the level of need. And that's what our policy is predicated on. I always want to add in pace to that, but for purposes of today, I'll just stick to what Michael Marmot says, to provide healthcare at scale and intensity that is equal to the level of need. And that's what our policies and our initiatives are doing. But I'll end by saying it's really important to change the narrative, look back to learn, but step into new territory to move forward, because we need to move the dial in a different way. And I do think that we need to focus on racist behaviour and who listens to who. Because I think if we unblock that, then we'll be well on our way to improving our outcomes for everybody. Thank you.
Thank you. Thank you so much, Jacqueline. You've highlighted so many important points around data, and we'll definitely come back to that. And also about the user experience, particularly as we saw with Mo's video earlier on today. Would love to talk about, and that really highlights for me the importance of community and engaging the community. And so, Tinuke, I'd love to turn to you. You are considered a global force for change. And I've just been so impressed with your work. And as a content creator, you've really built this network of mothers to support one another. So can you please share with us not only how these women have experienced racism as they seek care, but also what do they think some of the solutions are?
Thank you, and thank you for having me today. To answer your question, sorry, excuse me. Should have done that before? Yeah, probably. Sorry. Sorry, I'm used to being on Zoom.
This is all new for us.
I'd normally have done that on mute. To answer your question, yes, through 5 Times More that I co-founded with Chloe, we are speaking to hundreds, if not thousands, of black women all the time, and obviously the work that we do outside of 5 Times More. So I run Mums and Tea, Chloe runs Prosperity. So we're talking to black women and birthing people all the time. And I think the way that sometimes it manifests itself is when we hear stories about women not being able to, when they go and see health professionals, for example, fibroids, things like sickle cell, they're not being appropriately managed or even spotted in the first place. And I think it's important to note that, you know, through our 5 Times More report, the Black Maternity report, we have seen 1,340 black women respond. And I know a lot of people have said, you know, it's down to socioeconomic status, and it's, I think it's a little bit more than that, than some of the stereotypes that we have seen and heard. A lot of women that filled out the survey actually came from quite high socioeconomic statuses. They earned above the national average. They were educated. I think it was 1% of black women that filled out the survey didn't have any education at all. Over 75% of them had a degree and higher. And we're seeing consistently that black women are still having poorer experiences. So I think it's all round. It's something that you actually can't deny. And in terms of what they think should be improved, well, at the end of our survey, we asked, what do you think should be improved? How do you think people can best improve the care that you receive? And that's how we came up with our recommendations. And you touched a little bit briefly on data sets and ethnic coding. And one of our key recommendations from that report is that what gets measured gets done. I'm sure we've all heard that saying. So if you can't even get things like ethnic coding correct across hospitals and hospital trusts, within even hospitals themselves, there's inconsistency in the reporting when it comes to ethnicity. So we can't even see on a level what's going on behind the statistics. So even the data that we have is incorrect. If you only have to look at like Ockenden, for example, they had 9,000 missing sets of data. So we don't know what's going on behind those statistics, so we don't even have the right data. So I think it is very important that we are finding out the right data and listening, as you said, to women and their families.
Thank you. Thank you so much. You know, it just, one of the consistent themes is around data. We often say we measure what we value, and so thank you both for highlighting that important point. You know, I'd love to talk about models of care, and Jacqueline, you highlighted this a little bit in terms of just the NHS and being known for providing some of the best care in the world, and we've studied a lot of your models in the U.S. to try to understand what around maternal health care is working. And one of the things that stands out, in addition to having universal health care and universal primary health care, is really having a broad midwifery focus, right? And having an investment in midwifery care as well. And so would love to hear more of your thoughts. Benash, if you can talk a little bit about midwifery care, and then I'd love to hear about, you know, do you think there's equal and adequate access to midwifery care within the NHS? You know, just having such a high standard of care and maternal health care, there's just a lot of data around just the impacts of midwifery care on better outcomes, improved experience. And so what additionally do you think needs to be done, particularly since there's just such an intentional focus around ensuring access to midwifery care here at the NHS?
So we know midwives improve outcomes, the continuity, the relationship building, understanding who you're caring for and what information they need, access to information, it's all vital. Some of the issues that can come within that is the education that those midwives are being provided, and we've already spoken earlier, we're only as good as our evidence, and if our evidence is sometimes incorrect, you know, looking at colour as cyanosis, blueness in skin. I recently had a midwife who took her mother to A&E, and she said, my mum's not well, she's looking grey around the lips, she's looking ashen, and the nurse said, she doesn't look cyanosed to me, there's no blueness. She said, check her saturations, and she was desaturating. And it is that kind of, what are we learning in our universities? What is the curriculum based on? Are we actually conscious about cultural competency? We've spoken earlier about how important it is to be culturally competent in our practice. So bringing that into our education system would really improve the role of the midwives and be able to help them improve some of these outcomes. And the reality is midwives follow and support throughout pregnancy, birth and the postnatal period. So they are placed in a way that they can support if they are adequately trained across the board. So absolutely, that's one of those elements. I just wanted to come back to one of the other issues generally is systemic issues, systemic racism, systemic biases that we are not conscious of or aware of. And I used to be a cultural liaison midwife, which is a specialist midwifery role that I created based upon what was a different job title altogether. And in that role, I was privileged enough to be able to look at the data in my local provider trust and look at what the outcomes are based on ethnicity and put a matrix of country of birth, languages spoken and postcode. That was able to tell us how we can do targeted work in targeted areas. But also it told me where we are failing. So data sets are, ethnic coding is important, but systemically, when I made those changes in the local IT areas, and we can look at data better, we had an issue when it went to birth registration times because the NHS spine didn't recognise the changes we had made. So and then we were not able to give NHS numbers, therefore we had to revert back to a rough understanding of what someone's ethnicity may be, and therefore it's the multitude and multifactorial things, and unless someone is locally as well as nationally and regionally looking at these, we're going to continue to see these outcomes.
Thank you. That's such an important point in terms of that alignment at all levels, in terms of particularly around data and interventions. Thank you for highlighting that. Dr. Rajasingam, Daghni, thank you for being with us. We talked a little bit about midwifery care and data, and as a chief OB for Southeast England and a specialist in high-risk maternal care that really focuses in on inequities, how do you see racism impacting maternal mortality and morbidity and the result of that in your work?
In so many ways. So if I start by saying I'm struck by the demographic in this room compared to if we had a session talking about preeclampsia in general. And the biggest issue for me is one that society doesn't value women. We don't value women, full stop. And when it comes to women of colour, we value them even less. The data that we have, that we focused on in the last 4 to 5 years, we have known about for at least 15 years. And we went through a period of saying that it wasn't politically correct to talk about the data. But without the data, we won't uncover the systemic issues that we are facing. So in terms of practice, I think there are several things that we know, and we should approach this in a scientific, evidence-based way. What is the unwarranted variation that we can reduce in the care that we provide? The issues around 5 times more is these are avoidable deaths. 70 to 85% of them are avoidable. If we had done things differently, those women and their babies would not have died. And I think that's the area of focus for me. It's not all right to say it's just a pleasantry. Let's add it into a little bit of education. It absolutely has to be a core part of education, a core part of competency assessment. Cultural intelligence should be a core part of clinical training, whether you're an obstetrician, a midwife, an allied healthcare professional. But we still aren't there. So if we really are serious about this, there are some serious systemic changes that need to be made, not just within the NHS, but within the professional organisations that have a responsibility. But I also want to talk about leadership, because that is really important. And in front of you, you see a diverse leadership. We have leadership from the women, we have leadership from the profession. But when I look across meetings where we're influencing policy and we're influencing care, I'm afraid it doesn't represent the demographic of the women that we're serving. And when that representation isn't there, that focus won't be there, that prioritising won't be there. Tinuke's talked about women of education suffering from our maternity system. I'm a woman of colour, I've had 2 children, and I suffered from it as well. But it wasn't really until fairly recently, and because of the work of people like Chloe and Tinuke, that it was okay to talk about it. Actually, breastfeeding is a nightmare. Being forced to breastfeed is a nightmare if you haven't got the support. So how are we supporting women is really, really important. How do we advocate for them is really important. And as an obstetrician, I'm as much an advocate for women as my midwifery colleagues. So I think this issue about us really getting behind the systemic issues that we're facing is absolutely critical. And then if I come to the individual, when I'm providing care for a woman, I need feedback on how I'm listening to that woman. I might think I'm doing it really well. I might think that I'm providing her with care that is equitable to the next woman that I walk into. But we know that that isn't what the data shows us. When we look at that data, when we have the funding to look at that data, and again, when you look at research and research funding into ethnicity, you look into research funding for women's health issues, we are really poor relations. In fact, we are no relation at all. And those are things, again, that we need to address. So I do believe that we should have professional culpability for how we are treating women, how we are listening to women, because we know that that is an integral part of the care that we're going to provide so that we can keep them as safe as possible. It is a risky business. Most people, much of maternity care, much of the outcomes will be good, but it is those avoidable ones that we have to impact on now. And as Jackie says, at pace. We can't wait.
Thank you. Thank you so much. And I would also love to invite questions from the audience, the in-room audience, and the virtual audience as well, so don't be shy. And happy to integrate them into the conversation. Excellent. I see a question in the audience. And please introduce yourself.
Okay, can you hear me? Joan Sadler, Director at the NHS Confederation for Partnerships and Equality. Jacqueline and yourself, Chair, can we say in the room how wonderful it is to see this panel? I haven't seen this in the NHS before, right? Black people professionally talking about black people. So I'm not going to let that pass. And we have to say to the Observatory, this is really what we need to see, and thank you. Back to your professionalism, the question, and Jacqueline raised it, a few of you raised it. The theme has been, if there is no accountability for people to not have to represent the women in the room that they're caring for, how can we change that? And Jacqueline and I were at something yesterday where we talked about working with the chief nurse to start mapping that if you have in London still maternity departments who do not have anybody in their directorships who are black or ethnic minority in any shape or form, what is that telling us? So is there something more that we could be doing to really look at this idea of leadership that I've heard from most of you about?
Thank you. Thank you for that question. Really about how do we ensure accountability? Anyone? Feel free to, anyone can jump in.
Yeah, a really good question and a good challenge. And I was delighted to be on panel in a conference with you yesterday, Joan, just speaking about diversity representation, really supporting junior staff to not see the glass ceiling. And I think it starts with this, having a user by experience, having diversity on a panel like this. I infrequently step off a stage having spoken at a conference and not have many people from diverse backgrounds wanting to speak to me, and I never get to the coffee, I never get to lunch, because I am the one that's going through the line, and I humbly embrace that, because for every person that speaks to me that is non-white, they are saying, you give us hope and inspiration. Somebody like you is here, then we can do it too. Or will you help me? Will you direct me? Will you mentor me? And I might not get to coffee, I might not get to lunch, but it's quite cathartic. And to be able to support people who are thinking that actually before I saw you, I couldn't do it, and now I see you, I can. And that's quite special. So I think there's something about role modelling. I think just using another out of the childbirth experience, although we focus on menarche to menopause, or rather Daghni's not personally, but in terms of a work profile, but just thinking about on the other side toward the older generation, I took my mother for a scan of her knee, and my mum's in her 80s, and she had to turn and twist and move and roll, and she's a little bit like me in terms of having an opinion and a view. And when she came out, I said, "How was that?" She said, "It was absolutely terrible, but the radiographer was a black man, and he was really nice, and he was kind to me, and I really like him, and his name is," and she mentioned his name, and she talked on about her experience because of the caregiver. All I was interested in was what was happening with her knee. She was more interested in the fact that it was brilliant, it was amazing, and there is something about, as Joan says, just acknowledging that when we are in maternity services, and the stories from 5 Times More birthrights that say when a woman comes in established labour and is at the desk wanting help and support, and the person on the other side who is non-white and doesn't recognise the fact that she might not be red in the face and flushed, she might not be expressing visually that she is in excruciating pain, the white receptionist might turn to the white person who is not in established labour and say, "We'll deal with you first," because she might be flushed, visually pink in appearance, visually expressing a degree of discomfort. And I'm not saying one is better than the other. What I'm saying is that if we don't step into this space of understanding what distress looks like, then the stereotypes will continue to drive our care, and those women will potentially not have a good maternity experience. So just in a nutshell, there is something about having people that are diverse serving a diverse community.
Could I come to that?
Yes,
Jo,
please.
thank you for asking that. And I'm going to say 2 things. One, talk menopause. I am a woman of menopausal age. I'm on HRT, and I think if you're worried about it, please access healthcare and don't be fobbed off by a healthcare professional. So that's done. Very, very important. The intersectionality issue is such a problem. I've been there. The glass ceiling has been there. I am in a senior medical leadership position in a very large organisation, but I have been there, and I still go there with the discrimination, the biases, the surprise when I walk into the room. They've heard my voice, they've heard my accent, they don't expect to see this sort of person. And I believe, having explored gender issues, not just within healthcare, that if we don't go down quotas and we don't make people accountable for appointing in a representative way, we are still going to be in this catch-22. I have 2 daughters, 21 years old and 19 years old, and I thought when they were born, I was genuinely going to forge ahead in terms of women's health issues, women's issues. Sadly, we've moved so slowly. So quotas, and that's not saying that people who are not qualified enough or not good enough get into jobs. We've been waiting there in swathes. We just haven't been given that opportunity. And I think we've got to make that accountability there, and we've got to make people answerable. The res stuff that has been pushed forward is a fantastic way for us to start impacting on that. But we absolutely have to focus on that, because if it doesn't come from the top, it's not going to happen in the rest of the system.
I'm from the north, and there's a very definite north-south divide when it comes to representation, especially at senior leadership level, and I think there's not much being done in that regard. So I looked at for the equity and equality strategy, the local workforce, and the fact that our band 5, 6 representation was so low. We had approximately in our region 1,475 midwives and about approximately 95 of those were from Black, Asian, or diverse ethnic backgrounds, just kind of shows you there's some issues here. So I'm going to come to recruitment and application biases, and we really need to look at our job descriptions, because isn't it desirable if we have a multilingual member of staff? Because the amount of times I've been in a room and I've been able to speak a language when someone's in pain and that's just taken the stress away from them straight away has been extremely helpful. Isn't that helpful? How are we looking at our job descriptions and how are they being put out? Because as a marginalised midwife, I look at job descriptions, and if I have one thing missing, I will not put myself forward. I know, being on the other side and having done interviews, that I have my privileged counterparts who will have less, a lot less, and will put themselves forward. And it depends on who's putting themselves forward as well, to who gets the jobs. So if I saw that desirable is multilingual, or being aware of cultural awareness or cultural issues, cultural competence on a job description, I and people like me might be more likely to put ourselves forward, and will keep probably being persistent in it. So it's time we change the way we look at things, right?
Can you hear me? Okay, perfect. Can I shake that question up a little bit? So, sorry, professional troublemaker here. I am here for more representation at all levels. It's one of our key asks, right? But I don't think it's a case of just, let's bring in more Black midwives. I don't think that's the answer, because what are they learning? We have to remember that the curriculum is essentially white. It doesn't account for a lot of conditions and the way things present in Black skin. So you might be bringing in more Black midwives and more Black professionals, but if they're all learning something from a Eurocentric nature, nothing will change. Absolutely nothing will change. And let's not forget the fact that Black staff, Black midwives, Black nurses are more likely to get struck off. So what are we really doing there?
Thank you. Thank you for bringing that up. And so it sounds like there's the accountability piece, there's the diversity and representation piece, and let's change the curriculum piece and make sure that it incorporates all of the diversity that we're talking about. I know we have about a minute left, so we can hopefully have more and continue this conversation. It's obviously just the beginning as I see it. But I'd love everyone to end off with provide just one key point in terms of where do you see the most hope? What are you most hopeful for in advancing maternal health equity and really changing the paradigm? We'll start with Jackie.
Just in a very small nutshell, I think where I see the future is now. The fact that we have the Health and Race Observatory that is leading the way, helping us to step into uncharted territory, where they are not silenced, they are not shackled, and therefore anybody that aligns themselves with them are able to step into a space to ensure equity for all.
Great. Daghni?
Absolutely, with the Race Health Observatory and the work that you can do. But you asked, where does my hope lie the most? And I would say it's with the generation of younger women. My daughters don't put up with nonsense. They don't put up with equity. They don't put up with being told they're different or being treated differently. But I feel the responsibility to support them and make sure that the systems and the framework is in place so that they can do what is necessary and that we move that forward at pace.
I'm going to switch it up and I'm going to say in the community, because health literacy in our community means our community can advocate for themselves and hold us to account. So
I'm showing my age here. But in 1991, my mum, as a Black woman, was more likely to die. Now, they didn't know just how much because they didn't collect data on ethnicity. Fast forward to when I had my son in 2017, I, as a Black woman, was 5 times more likely to die. Now, I have a daughter. should she choose to give birth in however many years, I don't want her to be campaigning about the same things. So that's what I'm hopeful for, that she's not 5 times or 4 times or even twice as likely, that this is something that is a thing of the past.
Absolutely. Thank you. Well, thank you to all our panelists. Thank you to all our panelists, leadership, the next generation, community, the next generation, and we're not going to continue this. And I'd like to just say collaboration. I mean, what we're realizing is the connectivity amongst all of us across the ocean, and just the global need for change and how we can learn from each other and change with that. So I think the change is inevitable and change is here. So thank you all, and thank you for the audience. Really appreciate it.